Mark. And on behalf of the company, I extend you a very warm welcome. I also thank you for your time today.
That we talk about, and I've just mentioned a few of the diagnoses that are associated with this. And this, for example, is a disease which we don't see anymore that much, but which in the past was a very important disease, the pellagra. And these were the symptoms: dermatitis, diarrhea, dementia, and finally death. But this we don't see anymore that much. But here, beriberi is also a disease which we don't see anymore that much, but it shows how severe a disease can be. And of course, the first description of beriberi was done by a Dutch physician in 1630 in Java. When we take too much B6, then of course we can develop a peripheral neuropathy when this high dosage is taken over a longer time. Just recently we have found out that when we treat Parkinson patients with duodenal infusion therapy, and this induces a vitamin B12, B6 and folate deficiency and accumulation of homocysteine and metabolic malonic acid, this may induce acute and subacute polyneuropathy due to levodopa infusion. And of course, when we have patients with or people with malnutrition and pregnancy, then specific micronutrients deficiencies can also lead to neurodisability, for example, blindness, and in little children, intractable epilepsy with B6 deficiency and cognitive impairment if iodine or iron is not present. So the diagnosis of diabetes mellitus in a middle-aged individual reduces life expectancy about 15 years, and the diabetic complications in neuropathy are very variant again, and nobody knows why some people have this distribution of polyneuropathy, others have more proximal distribution, or if you have a neuropathy multiplex here where you have only certain peripheral nerves involved. So type 2 diabetes will become much more frequent in the near future and will result in more diabetes-induced death. Type 2 diabetes is a vascular high-risk situation accompanied by hypoglycemia, but this will be in our next symposium discussed in more detail. So I want to thank you for your attention, and this is a university clinic in Mainz where I'm working. Thank you very much.
I will introduce to you the biochemical part, not of clinical focus, but maybe with implications for treatment or choosing the preparation or the dose. So the biochemistry of B vitamins. In this slide you see the complicated structure of vitamin B12, which consists of a core-ring ring. In the middle of this ring is a cobalt molecule, which is the only natural molecule in the body containing cobalt. In this part, you see the bridge that enables vitamin B12 to bind to the enzymes or the carrier proteins, and the R substitute here is the one of interest for us because this can be either hydroxy, methyl, cyano, or adenosine. And in this case, cyanocobalamin was used, and this study shows in indirect way that cyanocobalamin is transformed into active cofactors and cause a reduction in homocysteine and in methylmalonic acid. The deficiency is common, in particular in elderly people or at-risk populations with some comorbidities. And B vitamin as a group have a synergetic effect. They ensure a sufficient delivery of methyl groups of glutathione and a DNA synthesis. The deficiency can be subclinical, and even we in the Western countries have difficulties, even with the sensitive biomarkers, to diagnose early stages of the deficiency. And in this case, it is always a decision to take: should we treat or should we not treat? In particular, if you cannot measure. The cyanocobalamin is effectively converted to cofactors. It lowers the metabolic markers, and it shows the clinical effect that is anticipated, and there is no evidence currently that the other forms are more or less active than cyanocobalamin. Thank you for your attention.
Nowadays there is a lot of work is going on microbiota.
Yeah.
So is there anything, something wrong going on in the microbiota and causing this B12 deficiency?
We don't even know, but I can imagine that if the
Gut
gut
microbiota.
bacteria is shifted, you may have a problem in reabsorbing the cobalamin that is secreted with the pancreatic juice, the free vitamin. But we don't have studies on it.
I do think that this is one thought which we can keep, because why a diabetic patient will develop a vitamin B12 deficiency? So there has to be some reason, and as it is being absorbed from the gut, so there is something wrong there as well.
Yeah, but in about the few years ago, we have a study. We give the B12 for the carpal tunnel syndrome, and then there are no significant improvement. Yeah.
Sure.
So the coffee might. So, but please be here at 7. Then all of us will walk through. There's a